Great. Assalamu alaikum, everyone. Welcome to our diploma program. Welcome distinguished guests, speakers, and participants to today's program. I'm your moderator, Dr. Rima Aslam. Before we begin the program, I would like to call Mr. Qayyum for the Tilawat-e-Quran. Please, Qayyum. Yeah.
आवाज सही आ रही है?
जी बिल्कुल आवाज आ रही है आप लोगों की।
You may start.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. قل أعوذ برب الناس ملك الناس إله الناس من شر الوسواس الخناس الذي يوسوس في صدور الناس من الجنة والناس. صدق الله العظيم.
Subhanallah. Thank you, Mr. Qayyum. Now let's move on to our first presentation by Ms. Arfa Khatun. She will take us through the DHIPC course journey. It is my pleasure to introduce Ms. Arfa Khatun, a renowned expert in infection prevention and control. As the founder of the DHIPC course, assistant professor at IUHS, and senior manager at Shifa International Hospital, Ms. Arfa Khatun brings a wealth of knowledge and experience. It's over to you, Ms. Arfa Khatun.
Thank you very much, Ms. Rima. प्लीज थोड़ा सा वेट, मैं अपनी स्क्रीन जरा शेयर कर लूं।
Okay, sure. No issue.
ओके, बिस्मिल्लाहिर्रहमानिर्रहीम, अस्सलाम वालेकुम। आप लोगों को सबको मेरी आवाज आ रही है?
Yes, we are audible.
ओके राइट, फाइन। थैंक यू रीमा। और आज हमेशा की तरह मेरे लिए बहुत खुशी का एक मौका है कि एक सफ़र जो हमने शुरू किया, अल्हम्दुलिल्लाह आज इसका 7th बैच है जो कंप्लीट होने जा रहा है, बल्कि हो गया है। और मैं उर्दू में इसलिए बात कर रही हूँ कि मैं हमारे साथ डॉक्टर शाहीन मेहतर, जो उनकी मैं जितने भी शुक्रिया अदा करूँ वो कम है कि वो आज हमारे साथ हैं, और वो बहुत अच्छी कराची वाली मज़े वाली उर्दू बोलती हैं, तो मुझे पूरा यकीन है कि वो इस उर्दू को भी समझ रही होंगी। तो थैंक यू वेरी मच डॉक्टर शाहीन बीइंग विद अस। और आज थोड़ा-सा मैं ओवरव्यू दूँ कि ये जो कोर्स हमने स्टार्ट किया था, इसका जो करिकुलम है, जब वो तैयार हो गया था तो डॉक्टर शाहीन मेहतर ने इसको चेक किया था और इसको गो हेड दिया था। तो ये हमारे लिए इसलिए भी वैल्यूएबल है कि इसकी कमेंट डॉक्टर शाहीन की तरफ से भी थे। हमारा ये जो सफ़र है ہاسپٹل انفیکشن پریونشن اینڈ کنٹرول پروگرام کا یہ 2017 میں اسٹارٹ ہوا تھا، اور اس میں بہت سارے لوگوں کی کنٹریبیوشن ہے. اس میں ڈاکٹر الطاف مائی مینٹور، مائی ٹیچر اور مائی گائیڈر، اور ان کی بہت بڑی کنٹریبیوشن ہے. اس کے بعد ڈاکٹر شامل اشرف جو ہمیں شاید جوائن کر چکے ہیں اس میں یا کچھ دیر میں جوائن کر لیں گے، انہوں نے یہ پلیٹ فارم دیا تھا کہ ہم اس کورس کو انڈس ہاسپٹل کے وہاں سے اسٹارٹ کر سکیں. تو کافی ایک لمبی اسٹرگل ہے جو ہم نے اس کو گزاری ہے. تو آج اس پروگرام کا کلوزنگ سیریمنی ہے 7th بیچ کی. اس کے بارے میں تھوڑا سا آپ لوگوں کو بتا دوں گی کہ اب تک ہمارا سفر کیسا رہا اور اس کو ہم نے اسٹارٹ کیوں کیا تھا. تو جب ہم نے اس کو انیشیٹ کیا تھا تو آپ سب لوگوں کو پتا ہے، آپ سب لوگ انفیکشن کنٹرول کے لوگ ہیں، کہ یہ کتنا بڑا چیلنج ہے، اسپیشلی ہمارے جیسے ملکوں میں جو کہ مڈل انکم کنٹریز ہیں. وہاں پہ ویسے بھی انفیکشن ریٹ ڈبل فولڈ ہائی ہے، ہمارے پاس ریسورسز لمیٹیڈ ہیں، لیکن اس کے ساتھ ساتھ ہمارے پاس نالج کا بھی ڈیفیسٹ ہے. لوگوں کو نہیں پتا کہ انفیکشن پریونشن اینڈ کنٹرول کو کس طرح سے کرنا ہے. بہت سارے متس ہیں، بہت سارے ایزمپشنز ہیں جس کی بیس پہ چیزیں ہو رہی ہوتی ہیں، اور جس کا الٹیمیٹ ریزلٹ جو ہے وہ خراب ہی نکلتا ہے. تو موٹیلٹی ریٹ ہائی ہے، موبیڈیٹی ریٹ ہائی ہے، نالج ڈیفیسٹ ہے، متس چلتے ہیں. تو اس کے لیے ہم نے جو اسٹارٹ کیا تھا ایک جرنی ہم نے کیا تھا 2017 میں، کہ کس طرح سے ہمارے ہیلتھ کیئر ورکر کو اس کی انفارمیشن ہو، اس کی نالج ہو، اور اس کو کس طرح سے ہم اس کو بہتر کر کے لے چل سکتے ہیں. تو الحمدللہ انیشیٹ کیا تھا انڈس ہاسپٹل نے 2017 میں، اور اب کافی ایسی سینٹرز ہیں جو اس کے اوپر ورکنگ سٹارٹ کر دیا ہوا ہے. NIH نے اپنا ایک آن لائن کورس انیشیٹ کر دیا ہے. اس طرح سے اور لوگ بھی اسٹرگل کر رہے ہیں. تو یہ بہت سارے لوگوں کو آگے آنا پڑے گا تاکہ ہم پاکستان کے اندر زیادہ سے زیادہ لوگوں تک یہ والی انفارمیشن پہنچا سکیں. تو جو کنٹریبیوشن انڈس کی ہے اس کو لے کے آگے چلا جا سکے. تو اب تک جو کورس کے حوالے سے اگر میں دیکھوں کہ کن کن ٹاپک کو ہم لوگ کور کرتے ہیں، تو آپ کے سامنے ایک لسٹ موجود ہے. ہم انفیکشن پریونشن اینڈ کنٹرول، بیسک ٹو ایڈوانس، مائکرو بایولوجی، امیونولوجی، انفیکشس ڈیزیزز کی جو گائیڈ لائنس ہیں، مائکرو بایولوجی ہے، بجٹنگ اینڈ فائنینسنگ ہے، سرویلنس اینڈ اسٹیٹسٹکس ہیں، ریسرچ کے اوپر کس طرح سے، کیونکہ پاکستان ریسرچ کے حوالے سے بہت کم ہے، اور کیونکہ اس کورس کے اندر موسٹلی لوگ نرسنگ ڈپارٹمنٹ سے ہیں، تو نرسنگ کا جو ایک آبجیکٹو ہے ہمارا کہ ریسرچ کے اندر نرسز کو اور آگے آنا چاہیے، تو وہ لوگ اس کو انڈرسٹینڈ کر سکیں کہ واٹ از ریسرچ اینڈ ہاؤ ٹو ڈو ریسرچ. تو اس کا ایک اسپیشل ٹاپک ڈالا گیا جس میں ایکسپرٹس ہیں ہمارے پاس. ڈفرینٹ جتنے بھی ٹاپکس ہم نے کور کر رہے ہیں اس کورس کے اندر، ان سب کی اسپیشلائزڈ فیکلٹی ہمارے پاس موجود ہے جو کہ اس کو ایجوکیٹ کرتی ہے. تو ID کے لوگ انوالو ہیں، ایپیڈیمیولوجی کے لوگ انوالو ہیں، ریسرچ اینڈ اسٹیٹسٹکس کے لوگ موجود ہیں اس کے اندر، اور ڈفرینٹ اسپیشلٹی کے لوگ موجود ہیں. تو اب تک کیا رہا ہمارا اسٹارٹ ہوا تھا کورس 22 اسٹوڈنٹ سے، جو ہمارا پہلا بیچ تھا. اور یہ کورس انیشلی 2-3 کورسز جو تھے ہمارے وہ کمبائن تھے، یعنی فیس ٹو فیس سیشنز بھی تھے اور آن لائن، لیکن اس کے بعد ہم نے اس کو پیورلی آن لائن کر دیا تھا. تو ہماری یہ جرنی ہے، اس میں لوگ شامل ہوتے گئے، اور ماشاءاللہ کافی گریجویٹس جو ہیں وہ اب یہاں سے نکل کر ڈفرینٹ ایریاز پاکستان کے اندر بھی اور پاکستان کے باہر بھی اپنی سروسز پرووائڈ کر رہے ہیں. تو ہمارا جو ہائیسٹ بیچ رہا ہے وہ 178 کا رہا ہے، جو کہ ہمارا 6 بیچ تھا. اس کے بعد انڈس ہاسپٹل جو یونیورسٹی میں جب آ گیا اور یونیورسٹی بن گئی اس کی، جو کہ انڈس یونیورسٹی آف ہیلتھ سائنسز کے نام سے ہے، تو اس نے اس اسٹوڈنٹس کی کو ایک لمٹ کیا. تو ابھی جو ہمارا ریسنٹ بیچ ہے جو پاس آؤٹ ہو رہا ہے وہ 129 اسٹوڈنٹس کا ہے جو پاس آؤٹ ہوئے ہیں، اور ابھی اپ کمنگ 8th بیچ ہمارا ان پروگریس ہے. تو الحمدللہ 8واں بیچ بھی ہمارے پاس آ گیا ہے. انیشیلی ہم نے اس کے اندر صرف نرسز کو لیا تھا، لیکن آہستہ آہستہ اس کے اندر MBBS اینڈ BDS کے اسٹوڈنٹس بھی شامل ہوتے چلے گئے، مائکرو بایولوجی کے لوگ بھی شامل ہوتے چلے گئے. تو اب اگر ہم دیکھیں کہ اب ہمارے پاس اچھی خاصی اسٹرینتھ ہے ہیلتھ کیئر ورکرز کی، جو کہ گریجویٹ ہو کے جا چکے ہیں یہاں سے. اس بیچ میں جو کہ 6th بیچ ہے، اس کے اندر 116 نرسز ہیں، 9 ہمارے پاس ڈاکٹرز ہیں، और 4 हमारे पास माइक्रोबायोलॉजिस्ट हैं। तो इस तरह से अगर आप देखें तो अच्छी खासी एक टीम है जो यहाँ से पास आउट होके जा रही है, और मेरी उम्मीद है और दुआ है कि ये लोग अच्छी तरह से अपने हॉस्पिटल्स के अंदर, सेंटर्स के अंदर इन्फेक्शन प्रिवेंशन एंड कंट्रोल की प्रैक्टिसेस को इम्प्लीमेंट कर रहे हों और उसको मॉनिटर कर रहे हों, और जो डे टू डे हमारे पास नए चैलेंजेस आ रहे हैं उसके लिए भी तैयार हों। तो थैंक यू वेरी मच रीमा फॉर माय presentation. Thank you.
Thank you so much, Ms. Arfa. It's such a wonderful that you are being with us since many years. So now I am moving forward towards Dr. Shaheen Mehtar. Our chief guest and key speaker is Dr. Shaheen Mehtar, IPC consultant from the South Africa. Professor Shaheen Mehtar, Professor of Infection Control and Prevention at Tigerberg Hospital and Stellenbosch University, is a renowned ICP expert. She graduated from the Fatma Jinnah Medical College and trained in the UK. She founded the Infection Control in Africa Network, developed IPC courses, and collaborated with Redbound University. She has served on international societies such as WHO and CDC guidelines development groups and published extensively. Her expertise spans IPC education, leadership, research, and global health. Moreover, I am so glad that she is with us and as a Pakistani healthcare professional making a global impact. Dr. Shaheen's achievements inspire us all. Her dedication to IPC excellence and mentorship has been invaluable. Please, Dr. Shaheen Mehtar, is now over to you.
Assalamu alaikum. Thank you so much. Look, I have a bit of a problem because I can speak Urdu, but I can't lecture in Urdu, unfortunately, because my thought process is in English, unfortunately. So you will bear with me, and I hope I'll try and go as slowly as I possibly can. Well, first of all, let me congratulate you on this amazing achievement. And I really enjoyed listening to Dr. Arifa. It's wonderful to see that there has been this progress made. It is very enlightening and very heartening to see what's going on, but also that people are not waiting for others, like the government, to do things for you. You've taken it in your own hands and you're moving forward. So very, very well done. Shabash. I think this is fantastic news. Okay. What I wanted to share with you, or I've been asked to share with you, is what have we been up to in Africa? Now, this has been quite a challenge. It still is quite a challenge, but I will actually take you through some of the things that are going on. And most importantly, I think it's how many people do we reach? How far do we go? So here is the true size of Africa. And everybody seems to think that, because of the amount of literature coming out from Europe and from other parts of the world, that it is a dominant country. But in fact, if you see how much we have to deal with, and I don't know whether you can see my pointer or not, but we're right here at the tip of Africa, and we have set up the program, which is the Cape to Cairo program, going all the way around. And as you can see, here's India. We don't seem to have Pakistan, but I would imagine Pakistan is about the size of Eastern Europe. So we have a lot going on. It is the second largest continent after Asia. It covers a total of 1/5 of the world's surface. It's big. But the thing is that unlike many other countries, we have very diverse populations, traditions, and culture. So it's very difficult to put ideas towards them which everybody would accept. And this is where research and information which is locally produced becomes very essential, which is what Dr. Arifa was talking about. And therefore, for us, it was a huge task to put this thing together. Nonetheless, we had to do it, so we did it. But I think there were some challenges, and I think we all recognize these challenges, some of which have been mentioned. Major challenges is that there's inadequate financing. And while you have probably not the same problems we have in Africa, but we do have a lot of war and displaced persons. And I have worked with MSF and with other organizations working in refugee camps and so on. And I can assure you, and I've in fact even worked in Afghanistan with the Pakistan refugee group with the Red Crescent. So there is a lot that we can do if we want to. And this is what we have to learn. How do we do this? What is it that we can actually do? So, the amount of money spent is very little, is less than 5%. And there is, of course, a clear association between sanitation and infant mortality. which is obviously evident. It is improving, but obviously not as fast as we would like to see it improve. There's a skills gap, but one of the things that has happened is there has been a large export of skilled workers from all low to middle income countries. I can tell you from Africa, we have got 65,000 African-born physicians working abroad, 70,000 nurses working somewhere else. And so these are people that we have trained who are now in a position to leave. And I really don't mind whether they leave or they don't leave. But what we would like to do, and perhaps this has been happening certainly in India, and we are now doing it in Africa, is that we are trying to engage the diaspora to come and work with us. And I think it's also happening in Pakistan. So that even though they have left, we want to maintain and look after their relationship with us and improve the knowledge. We have no structured paths, career paths, and certainly we're building on that quite relevant. It's relevant to all of us that, if you don't have a career path, nobody's going to do the specialty in infection control. Surveillance is very limited, even though we have now joined with the GPPS and doing syndromic surveillance. And of course, there's a limited laboratory backup across Africa. The one thing which I found, which was very helpful to me when I was in Sierra Leone working on the Ebola outbreak, is that the indigenous knowledge that exists in the country is really important. And we don't give this enough credence because we think it's hocus pocus. But there is a lot of hocus pocus, yes. But there is also some in-depth indigenous knowledge that we need to think about. The communities are not well informed about Western medicine, but there is that information which can be used, and the healthcare workers come from that community. So we must see what they have available to them in the community. And of course, evidence-based policies from high-income countries are very difficult sometimes to follow because we don't have that information. We don't have the infrastructure to allow us to do that. Now, I just want to raise something with you, which is a problem that I've come across and a challenge is actually looking at the difference between training and education. So basically, training is the action of teaching or learning a skill or behavior. So you don't have to have any great, fantastic ideas. You just need to learn how to do it. Education, on the other hand, is what we are talking about. We're talking about the acquisition of knowledge through a process of receiving and giving instruction. So the best way to learn is to teach, as we all know. And I think it's very important that for those of us that are engaged in this, must understand that when you're training or educating, what the difference is. In training, there's a pursuit of ability, there's a learning to do, whereas in education, there's a pursuit of knowledge and there's a learning to know, okay? Training is quite short-lived, it's mechanical, it doesn't get sustained, and this is why we have so many people coming from outside agencies coming to Africa, training, teaching, doing whatever they get. A lot of funding is provided to high-income countries to come and train in low-income countries, which I don't understand because we should be getting the money to be able to do our own training, but because they don't trust our knowledge, I suppose, and they don't trust our systems, I suppose, they actually allow, so you'll have people from Harvard and Johns Hopkins and all these wonderful people coming to us to tell us how to do things when they've never lived or worked in our environment. And that to me is a really big problem because I think personally we should be the ones doing our own training, as you guys are doing, as we are trying to do. With the education, you can start learning it, and you can lead to an understanding, and then you develop it, and it becomes sustainable. So, for example, if you have understood the terminology or the requirement for a healthcare-associated infection, you might be able to develop a syndromic surveillance program without having laboratories, because otherwise people would say, well, if you haven't got microbiology, you can't do surveillance. Well, we've actually managed to do some of that, okay? So much of what happens in Africa is actually training and not education, which is very annoying because it doesn't stay where it wants to. This is the National Strategic Framework, which I was very involved with. I chaired the committee, and of course, we put the basic training program in place. And it's from basic to an intermediate to an FIPC and going up to the IPC, which is the one that Samina did with us. And we have had some more applications from Pakistan this year as well. And then you can go up and do your academics if you want. But to my mind, this is a really important thing because it goes from training here. so that everybody knows what's going on and goes into education. And the one thing I noticed by the topics that you guys are covering, which is wonderful, is that it's quite microbiologically leaning. So you would perhaps want to think about adding a bit of decontamination, even though I attended some very nice talks from your students on decontamination and the built environment, which is now becoming a huge issue, particularly with ventilation. Now, I wanted to say this because this is quite important. This is a traditional healer. This lady here is a traditional healer who is part of the advisory board on antimicrobial stewardship in Zambia. She is the liaison person for us. And mind you, she is very powerful. She may not look very powerful, but I'm telling you, she's very powerful because the community trusts her. They don't trust people in white coats and overalls and yashmaks and God knows what else are walking around with all this old paraphernalia. They trust people that look like them. And when you have the outbreaks and you've got all these hazard suits and so on, they really get very upset. So this is the sort of person you want to have on your side. And she should be part of the program, but she was not allowed to participate till recently when we've engaged with her. In Pakistan, you have a great asset. You've got lady healthcare workers who go into the community. And when my father was alive, Allah Jannah Nasib, he was actually, he set up a big program in the rural areas of lady healthcare workers, introducing infection control as hygiene, if you like, in that community. Now, the barriers to teaching is very common. We all understand and know these barriers. It's culturally, you don't argue with your elders. जवाब नहीं देना बड़ों के सामने बुरी बातें नहीं करना ये क्या बात कर रही हो तुम. So you don't do that. So there's no debate allowed. And I think we have to break that mold. I want to listen to the young people. I want to hear from them what they have to say. And their minds are much sharper than mine. And they have a lot more to say. So that is very important. The second thing is you can't let anybody know how much you know because the seniors feel very threatened. I raised you and now you're behaving like this. Okay, so that's a bit of a problem. You cannot tell the older person what to do because that is considered insubordination. And I know it's in Pakistan, but my gosh, it's really, really strong in Africa. So we really have to be very careful how we approach and who we promote and what young people can go forward and how they can do it. The other problem is that nurses cannot advise doctors, which is really daft because some of obviously I was trained by nurses in infection control in the UK. And I mean, they are the ones who actually do the physical work. So it's really important. And house staff cannot challenge nurses. So you can't have the cleaners talking to nurses and telling them that, look, this is happening or that is happening. It's a bit of a problem. The education and language is a problem, and this is because education done by outsiders, either in English or French, and the words are different, and the connotation is different, and people don't quite understand what's going on. So it's really quite important that we understand the context of how we are approaching things and whether this is appropriate to our part of the world and the applications. The use of words could be misinterpreted or they could be misconstrued, and that makes a big problem when you're trying to develop policy and programs. So we usually try and get people locally to speak to everybody. However, the senior staff are quite au fait with English. In some part, they're more French speaking, but we managed to deal with that. And of course, the resources, both human and financial, there's evidence, lack of evidence, and we've talked about this, and we have to look for trained and qualified tutors, mentors, and support, okay? Accreditation is starting slowly. It's very difficult at the moment, but we're getting there slowly. So what we do is we actually want managers on our side, okay? And the way you talk to managers is about money. पैसे की बात करते हैं उनसे. So what you do is, what we did anyway, is that we looked at the infection control when it started at Tigerberg, and we measured how many infections we avoided. We costed this as a minimum, excuse me, of 250,000 intensive care unit. And we show IPC started, and we showed that there was a reduction. This is a huge amount of education. Obviously, in the hospital, we had we had about 2,500 staff, and we had to educate almost everybody. Then in 2009, I went off to write a book, and everybody else, and my colleague was pregnant, so she went on maternity leave. And we landed up with one person covering 1,300 beds in the hospital. And you can see the impact of that. It went up, which is here, 47. And the cost increased by 11.7 million. When we all came back in team, we all managed to come down. So what we showed them is we saved them 89 million, of which we got 10 million to develop a brand new state-of-the-art sterile services department, which was put in place. So if you talk to them about money, it really helps. The other thing is that we changed the method of information delivery. Rather than giving them reading and go off and do what you want, there was a lot at the time of changing to visual, because that's the way people learned best. And they were doing visual, increased face-to-face discussions. Africa is too big for us to do that anymore, but that is what we did initially. And the next thing we did was a lot of role playing, which actually helped a lot. Okay. Now, pre-pandemic, there were various IPC provisions varied across the health services, depending on the provinces. IPC was not recognized. There was no established career path, especially recognized training. So here we had over 2,000 infection control people trained across Africa, and they were in positions, but they were not given the compensation for being infection control people in that regard, which is a bit annoying, really. So then it was considered a nursing specialty, so doctors didn't want to get involved, which is very difficult because we needed IPC teams with doctors and nurses to go on to clinical ward rounds and talk to the clinicians. And research obviously was limited. A lot of people thought we were spying on them when we were collecting data on HAI. So this is really not very good. It's getting much better because we're now using the GPPS system. Guidelines and policies which did exist were neither advertised nor promoted because everybody was following the CDC guidelines or the WHO guidelines. So our guidelines were sort of just sidelined, even though they were very effective, and only came to being much later on. And of course, nothing much has changed since post-pandemic. However, what did give recognition in Africa were two major things. First was this Ebola outbreak that took place in West Africa, which I was quite involved with. And secondly was the COVID outbreak that was involved in the Congo, which I was not involved with at the time. What I found, or what we found, was that the WHO and the CDC were both very ill prepared for these outbreaks. They had 5 people, I think, Ben was telling me, 5 people in CDC Atlanta, and there was nobody except Bernadetta and another couple of people at WHO headquarters. So they used all the ICANN trained people to go into look after this program. And so therefore, all of a sudden, about 200, I think it was 173 plus 3, plus 30, were actually engaged in being advisors with the WHO, consultants with the WHO, going out there and working with CDC and working with the WHO. And this was where we had to then go in. They asked us to go in and provide the training and mentorship to West Africa and during Ebola, and they took this responsibility. So all of a sudden, they became visible that these trained group of people can be used. And I want to show you something here that we did. And what these 2 slides tell you, okay, so I wanted to just put forward to say that we did an assessment of pre and post training. So this is the training in Sierra Leone where everybody had been trying to teach and train and do whatever. There were there were 3 groups. So this is, you can see them here. The pre-test increase was shown out of these 3, all of them had an increase in knowledge of 22%, except this last group. And what is very interesting about this last group is that these were trained by us from ICANN. This group was trained by people from CDC Atlanta. And what happened was, because they didn't know what they were doing, they caused so much chaos and confusion that people started losing knowledge rather than knowing what was going on. Now, this was very clear to us, and we actually presented it to CDC and said, listen, guys, you know what? If you don't know what you're talking about, don't do it, okay? Don't send a second-year student with a piece of paper telling us what to do when we are healthcare workers in Africa, been working on this program for the last, so to 60 years or something. So this was very evident. But what was also very interesting is that the same batch that we looked at, between March and October, we went back to train. There was very little increase in their knowledge. And the reason for that was because their level of knowledge had saturated. And this gave us a very good indication of our training program working. You can see they go from 11 to 29 here, but here they go from 68 to 81. It's brilliant, absolutely fantastic. And we were very proud of this. The other thing was it reflected in the mortality that we were looking at, because the time between symptoms and hospitalization was reduced to less than 2 days with people with Ebola, which is fantastic. It decreased the number of new infections in healthcare workers, which is what we wanted, and it decreased the unsafe burials. So you can see here, this is the differential where the training happened here and IPC training happened here. You can see how there's a decrease in the total number of deaths and cases. So that was very helpful. So now, if you're looking at the front line, this I got from the news from Dawn, looking at what happened in Pakistan and how you can help. So you're a specialist. I want you to think about yourself as the specialist, okay? As an IPC specialist, you have to learn to think outside the box. You don't have the facilities they have in Europe or in the global north, but you have these. You have us. We are here. So you need to use that facility. And one thing that happens for stupidity of the greatest extent is looking at how dangerous practices are started. For some reason, this spraying of humans started during Ebola, and everybody was being sprayed, except me. I refused to allow them to spray me. And so what happened? What are they doing? What exactly is it that's going on here? There's absolutely nothing going on here. And what we found is that we did a study looking at exposure to chlorine with single and multiple use. And this was amongst healthcare workers who were so precious to us. We looked at their eye problems, breathing, chest, and burning throat. And all of these were statistically significant increase. So it didn't prevent any transmission. All it did was cause very, very major side effects. And I would implore you, please do not spray humans with chemicals. It's such a bad idea. Okay, this was the COVID training for us for this year. So this was quite interesting to us as well, because all of a sudden, every Joe in town became a trainer because there was money involved and people were being paid to go and train. So there were 78% of them received training. But look who was training them. There was an admin person who was training them. There was some doctor who was wandering around, I suppose, and decided he's going to train. There was supervisors training them, but the outside agency, 71% of these, about 31% were the IPC teams, and 40% plus were outside agencies like the WHO or equivalent. Okay, and what was very interesting is what did they cover? Now, if you were working with the infection control group, you knew that ventilation was the most important thing, particularly since we could do something about it. Guidelines were essential, and I think I wrote the guidelines in about a week. We had to get all the guidelines out there. But what everybody was jumping up and down with was the least effective, which is the PPE. That was what everybody was using. But in fact, what we needed was something else. So elimination, where we were looking at triage and screening, was apply the COVID bundle, isolation facilities, following the guidelines, but that is not what was happening. And what was more interesting, and I want you to note this, that of the 345 students that we were talking to, 42 of them had less than 1 day training to deal with COVID. How do you do that? 25% had 1 to 3 days. And these are people that were having COVID, that acquired COVID, and later on, most of them actually recovered, but some of them even died from it, But what they needed was at least 3 to 5 days, at least, of training. And this is what the infection control people provided and the outside agencies provided. But look at the topics that were covered by this lot here. So all they did was tell them how to put on and take off your PPE, which we know, hand hygiene, which we already do, standard precautions, which we already do, donning and doffing. But look at how few people talked about ventilation, environmental cleaning, and the guidelines. Okay, so I think it's really important that we understand what it is that we are doing. This is just to show you that the impact of this interesting training and and how that impacted on those that were infected or not infected. So if there was non-AGPs, in other words, they only needed to use a surgical mask, etc., they got infected. This is from the infected group, but they were using gloves and they were using all sorts of other things as well. However, in the non-AGP group that were not infected, most of them were actually using surgical masks. So that was quite important. For those that were infected with AGPs, very few of them were using respirators, whereas those that were not infected knew. In other words, they understood how to use their PPE to protect themselves, okay? All right, very quickly, I hope I'm not going too far, but I've got to expand on this to just let you know we are one of the largest organizations, and our main strength, of course, is training and teaching. We are trying to do some research, but it's really, really difficult to do that. Now, because we're such a big continent, it's really difficult to get from point A to point B, and the traveling is much, much more expensive than you'll ever imagine. So what we've actually done is when they used to come for their diploma, the cost of the course would not be nearly as much as them having to travel and to stay. The cost was far, far higher. So we decided that we're going to go into the teaching platforms from face-to-face. We've gone on to the online virtual learning platform on Zoom, on Echo, which is doing a lot of now, webinars, podcasts, and then we're doing a hybrid method. At the moment, we're doing a lot of Echo training. What it did show as pre and post COVID was that pre-COVID, because we were face-to-face, people couldn't come. So there were very few people coming in right up to 2019. Then in 2021, when we restarted looking at our fundamentals in IPC, which is the 6 months course, you can see that there's a huge increase. And now, and this time around, we had 70 students to train. So, and you can see people from Uganda, from Zambia, and these are the countries at the bottom here who come into that course. And this is the prep course that goes into the diploma. And the postgraduate diploma, as you know, they started at the beginning, we were only 7 countries as we were going along, mainly from South Africa because they didn't have to travel so far. But later on, that actually became quite big. And here is Samina. She was, it's a great pride to have her in our cohort. And you can see that now we are into 17 countries. And this year, I think we're going to be a bit more than that. So that's quite a bit of expansion. What happened was that and then obviously we asked the students anonymously to tell us what they thought of the classes and what did they find useful. So they said less travel time, the interactions was good between us, because unlike a lot of other online courses, we are always available via WhatsApp, as mentorship, as discussions, as being available. You could ask us questions during the whole time that we're there. So there was really quick. And then there were polls that we did with them. There were breakout rooms where peer-to-peer education was going on, lots of discussion groups. So they did enjoy. We made it very, very interactive. The virtual classroom that they found challenging, one person said it was impersonal. The main challenge was, of course, the internet. It was a big, big challenge for them. And we had, of course, load shedding going on as well. So that didn't help a lot. But now that is much improved. And this did help us a lot. The 95% thought that the relevance of the content was good, and increasing of knowledge, again, 95% thought it was either excellent or good. And the application, again, they thought was very good. So they thought it was either outstanding or very useful. And we also got them to evaluate the tutors, which I thought was really important. The quality of the presentations were excellent, they thought. The quality of the lecturers, they thought, were very good. The relevance of the course, they thought. I think they were just being polite, really, because some of the tutors were really awful. But I think they were being polite. So topics that were taught, did the tutor, was the tutor an expert in this, or were they just rattling off something they'd learned from a book? Could they simplify complex concepts, which is absolutely vital for infection control? And how was the information retained? Did they do anything memorable to make you understand what was going on? Like, for example, when I was actually teaching them about PPE and COVID, I was saying, do this, okay? You protect your eyes, your nose, your mouth, and your hands, all right? So this is how you do it. And that became a sort of a logo, if you like, for everybody in the class at the time. We had they had availability to go back and look at the recorded lectures, and many of them did that. And this is some of the comments that they made. That was an eye-opener. My knowledge has really grown to a point of positive confidence. I can talk to and share knowledge with others. And this is really, really important, that an infection control nurse practitioner can talk to a doctor with great confidence. I say, listen here, this is what's going on. We can't have you doing this. And the guy said, well, I'm a doctor and I know what I'm doing, but you don't actually. Just because you're medically qualified, it doesn't mean that you know infection control. Okay, so I think it's really important that we understand that, and this gives them the sort of confidence to do that. And they said that they did find it very helpful and very useful. And of course, one of the students said we need more managers and leadership course to take this forward, and we've engaged with that as well. In our own institution, we introduced the Shield of Excellence. So every year we would do the evaluation, which was done by the Infection Control Unit, looking at the healthcare associated infection rates, the provisions they had, standard precautions, transmission-based precautions, the number of staff they trained in IPC, the link nurse program. And then they won this shield and they would love it and they would be displayed and they would be so excited about this. So it really was one of the very, very important things. So graduates, as I finish, I'd like you to think about this. We are short in the world, and particularly low to middle income countries. So remember, you are unique, okay? You are going to carry this flag forward in infection control. You're going to deliver healthcare safely to patients and to yourself and base this on evidence and not some myth that somebody decided to pass on, like spraying of humans. Understand the community and work with them closely so you can learn from them and teach them in the nicest possible way. And then really reassess the way you teach. Think of innovative ways of getting the message across. So you need to know your audience. Okay. And there you apply global principles to local practice. All right. And congratulations, all of you. Well done. And I hope many more of you go forward, carry the banner and make Pakistan and other parts of the world safe. Thank you very much. Shall I stop sharing now?
Right. So thank you so much, Dr. Shaheen, for sharing your valuable insights with us. Your presentation was truly captivating and informative. Thank you so much.
You're welcome.
Now moving towards our next facilitator, Dr. Altaf Ahmad, Chairman of Infection Prevention and Control at Pakistan Kidney and Liver Institute. Brings over 25 years of experience in research, teaching, and laboratory management. He served top 10 institutions, led MMIDSP as president, and contributes to Ministry of Health, Punjab's technical working groups with 48 peer-reviewed publications and contribution to national guidelines. He is a renowned expert in the infection prevention and control. Now it's over to you, Dr. Altaf. Dr. Altaf.
Assalamualaikum, Reema. Thank you very much. And बहुत शुक्रिया. It was so wonderful to listen to Dr. Shaheen Mehta once again. और जब भी इनकी बातें सुनता हूँ तो एक नया जज्बा, एक नया जोश आ जाता है. We have been talking about IPC in Pakistan since a long time. Dr. Shaheen has been visiting Pakistan off and on. और आप लोग फॉर्चुनेट हो कि उन्होंने जो बातें कही हैं उनकी हर स्लाइड में एक मैसेज था. आई होप कि आप इसको दोबारा सुने, देखें, और ख़ास तौर पे आरफा और दूसरी टीम जो इंडस की है जिन्होंने ये कोर्स बनाया. दे हैव सो मच लर्निंग एंड इनसाइट व्हाट हैज़ बीन डूइंग इन अफ्रीका, किस तरह से वो आगे चीज़ें लेके जाना चाहिए और कैसे उस पर बढ़ना चाहिए और अपने ऊपर कितना भरोसा करना चाहिए. यू शुड हैव ऑल द कॉन्फिडेंस. यू सी, जो आईपीसी के जो बच्चे हैं उनको मैं मुबारकबाद देता हूँ जिन्होंने ये डिप्लोमा कोर्स किया. लेकिन अगेन एजुकेशन का ये एक पार्ट था, ये पहली सीढ़ी थी. जाहिर है आप किसी को समझाने जा रहे हैं तो आपको खुद आना चाहिए वो चीज़. आपने कितनी अच्छी तरह पढ़ा है नहीं पढ़ा. मैं बताऊं आपको कि आजकल हमारा हॉस्पिटल JCI एक्टिविटी की तरफ जा रहा है, बट एवरीवेयर इन एवरी कॉर्नर ऑफ द हॉस्पिटल वो हमें बुलाते हैं आईपीसी वालों को. और उसमें मेरे साथ आईपीसी के नर्सेज भी हैं, दूसरे लोग भी हैं, और कुछ टोटल 4 लोग हैं हम, और पूरा हॉस्पिटल हमें देखना पड़ता है. लेकिन वो हमें इतनी इज्जत देते हैं और इतनी जगह पे बुलाते हैं, हर चीज़ के बारे में हमसे पूछते हैं. चाहे वो बिल्डिंग और फैसिलिटी मैनेजमेंट हो, चाहे वो एयर कंट्रोल हो, चाहे वाटर स्टैंडर्ड्स हो, चाहे RO प्लांट हो, डायलिसिस, ICU, इमरजेंसी सर्विसेज, सर्जरीज, surveillance, monitoring, environmental cleaning, everything is there. और उन सब का स्टैंडर्ड एक है जिसको हमें मीट करना पड़ता है. और आईपीसी की अगर नॉलेज ना हो तो आप खुद सोच सकते हो कि ये कैसे होगा. ये डिप्लोमा जब शुरू किया था 2017 में इंडस से, तो यही ख्वाब था कि ये आगे बढ़ेगा चाहे कोई हो या ना हो. मैं भी वहाँ से चला गया एंड लेटर ऑन आरफा भी रीलोकेट हो गई. लेकिन आप देखें हम अभी तक आपके साथ जुड़े हैं, और जो भी बैच आता है और जब ये सेरेमनी होती है तो इतनी खुशी होती है عارفہ کو پتہ ہے مجھے کتنی خوشی ہوتی ہے. سو اس چیز کو لے کر آگے بڑھیں. آپ کو پتہ ہے پاکستان میں کمیونیکیبل ڈیزیزز، انفیکشنز، چاہے وہ کمیونٹی میں ہو چاہے ہاسپٹل میں ہو، بہت بڑا امپیکٹ ہے اس کا ہمارے معاشرے پہ. اور ہمارے لوگ ابھی تک اس طریقے سے ان میں اویئرنیس نہیں آئی ہے. لیکن جیسے جیسے یہ کورس ہو رہے ہیں اور بھی لوگ کورس کروا رہے ہیں، اور آئی ہوپ کہ جیسے ڈاکٹر شاہین مہتر نے ایڈوائز کیا کہ وہ کورس ہونا کیسے چاہیے، اس کو کن چیزوں کو ایڈریس کرنا چاہیے کہ لوکل لوگوں کو اور لوکل نالج کو کیسے استعمال کرنی چاہیے. صرف CDC کی گائیڈ لائنس کو فالو نہیں کرنا چاہیے، یہ بھی دیکھنا چاہیے کہ ہم اس کو کر بھی سکتے ہیں کہ نہیں، ہمارے کیا ریسورسز ہیں، ہمارے کیا ٹیمپریچر ہے، کیا موسم ہے، وغیرہ وغیرہ. سو یہ ساری نالج اس کورس میں ہے، اور آئی ہوپ کہ اس کورس میں بھی مختلف قسم کی ڈیولپمنٹ ہوتی رہے گی، اور جو کہ اچھی بات ہے. ہمیشہ کچھ نہ کچھ چینج آنا چاہیے. میں یہی سمجھتا ہوں کہ یہ کورس کرنا پاکستان میں پہلی دفعہ بہت اچھی بات ہے. ایسے بہت سارے کورسز ہونے چاہیے اور مختلف جگہوں سے ہونے چاہیے، تاکہ وہاں کے لوگ، پاکستان بھی ایک بہت بڑا ملک ہے، 24 کروڑ کی آبادی ہے. سو مختلف صوبے، مختلف لینگویج بیریئر کو کور کرتے ہوئے مختلف صوبوں میں اس طرح کی ایکٹیویٹی ہونی چاہیے. میں آپ کو بتاؤں کہ جب ہم ہائرنگ کرتے ہیں تو اگر ہم دیکھتے ہیں کہ انڈس کا ڈپلوما کیا ہوا ہے تو دیٹ از اے ویری بگ پلس پوائنٹ فار دوز کینڈیڈیٹس، کہ اگر انہوں نے کیا ہوا ہے تو ہم یہ سمجھتے ہیں کہ یار ان کو کچھ تو آتا ہوگا، انہوں نے پڑھا ہے. نالج ہمیشہ یاد نہیں رہتی، ناٹ رٹافیکیشن، بٹ اس کو سمجھنا اور پھر اس کو ہلکی سی ٹریننگ اور کچھ وقت گزارنے کے بعد ایک ایکسپیرئنس. لیکن یہ جو بیک گراؤنڈ ہوتا ہے اس کی وجہ سے ہم جب بھی چنتے ہیں کسی انٹرویو کے دوران، اگر انڈس کا ڈپلوما ہوتا ہے تو ہم اس کو بہت ہائی پوائنٹس دیتے ہیں. سو دس از دا وے اٹ شوڈ گو آن. اور اس اسٹینڈرڈ اس کا اور بھی زیادہ ریز ہونا چاہیے، اور بھی زیادہ ٹیکنیکل اور پریکٹیکل چیزوں کو جو ہمیں جس کی ضرورت ہے ہمارے ملک میں، اس کو ہمیں دیکھنے کی ضرورت ہے. سو ونس اگین کنگریچولیشنز ایوری ون، اور میری طرف سے بہت بہت مبارکباد نہ صرف اسٹوڈنٹس کو بلکہ وہ پیچھے جو ٹیم ہے اس کو. اور آئی ہوپ کہ یہ سارے اسٹوڈنٹس اس ٹیم کی ہمیشہ عزت کریں گے جیسے کہ ہونا چاہیے، جیسے استاد کی عزت ہونی چاہیے. سو آئی ہوپ کہ یہ اٹ ول گو آن فار ایور. تھینک یو ریما.
تھینک یو ڈاکٹر الطاف احمد. اینڈ ونس اگین آپ بہت اچھی باتیں ہم لوگوں کو سکھاتے ہیں اور وقت سے بہت چیزیں لرن کرتے ہیں. اینڈ تھینک یو ایوری ون فار سپورٹنگ us and guiding us through this journey. Now we are having the honor to have Dr. Tina Shamsi, Associate Dean at Indus Hospital and Indus University of Health Sciences, and Consultant and HOD of General Surgery. Her expertise spans academic leadership, surgical innovation, and healthcare management. I would like to invite Dr. Tina Shamsi to provide her insights. Please, Dr. Tina, now it's over to you. Dr. Gira, are you there?
Can you hear me?
Yeah, it's audible.
I'm sorry for joining in a little late. I'm in the theater today, but I would like to extend my gratitude to Ms. Shaheen and Dr. Altaf. Dr. Altaf has always been a part of Indus for us. Arfa Khatun, the IC team, for managing this course so effectively. I would also like to borrow a leaf from what Ms. Shaheen said in her presentation. It's a wonderful presentation that we need to utilize and look into our local resources. ہمیں اپنے local resources, local جو commitments ہیں کیونکہ وہ relatable زیادہ ہوتی ہیں. So borrowing a leaf from that, ہم لوگ انشاءاللہ اس کورس کو اور آگے لے کر جائیں گے. We have a joint partnership with other institutes تاکہ کیونکہ انڈس کا مشن یہ ہے کہ ہم کسی بھی طرح لوگوں کو بینیفٹ دیں، چاہے وہ مریض کی علاج کی صورت میں ہو یا تعلیم کی صورت میں. So if anybody can benefit from these courses, we are more than happy to help out. एक और चीज जो शायद इस फोरम पे बताना मैं चाहूंगी कि वो ये है कि we've also started a housekeeping course, because housekeeping वो एक एरिया होता है जो इन्फेक्शन कंट्रोल का इनडायरेक्टली पार्ट होता है, and I think they're overlooked. So the IC team at Indus, all hats off to them. They have started a great job in training our own housekeeping in infection prevention and management courses. And I think it is a great opportunity for all other people to come forward and represent their hospitals, push their hospitals in doing similar things, because again, and then it will benefit the patient. So best of luck for your next course. And I would now sign out, and I would like to thank everybody who was present here, and especially Ms. Shaheen for taking out a valuable time for us. Thank you.
Thank you so much, Dr. Gena, and highly appreciate those words that you have explained right now. And definitely we will work hardly and do our best. So now moving towards the next, our facilitators, like we extend our sincere appreciation to our facilitators from various esteemed universities and hospitals who have generously shared their expertise and time with us. So I would like to share a slide for them. All right, so we are very thankful to them that they are the part of this diploma, and they work tirelessly for improving our education sessions, and they are doing their best with us. And thank you once again. So now moving towards course distribution, certificate distribution ceremony. So stay with us. And here we are moving towards our next one-year diploma in hospital infection prevention and control. So firstly, I would congratulate to all of you that who worked harder in this course and to pass out this course. Thank you all for joining us. And now moving towards the next slide and congratulate once again. I would like to call their names as well. So let's begin. All right, so Dr. Muhammad Bilal, congratulations that he got the first position in this diploma. And the second position is Mr. Khurram Shehzad. And now the third position is Ms. Iman Ahmad. Congratulations to you all. And now moving towards our next candidates, Ms. Abida Parveen, Mr. Ali Hassan, Ms. Alisha Atiq, Ms. Amina Shehzadi, Mr. Amjad Ali, Ms. Amna Liaquat, Ms. Anam Shehzadi, and Ms. Aqsa Anwar, Mr. Asif Ali, Ms. Asia, Ms. Asma Gul, Ms. Aisha Akram, Ms. Aisha Anwar, Ms. Aisha Aman, Ms. Aisha Beg, Ms. Azra Rose, Ms. Bini Zahra, Ms. Bibi Zainab, Ms. Cecilia, Dr. Adil Bashir, Dr. Mehwish, Dr. Muhammad Shafiq, Dr. Kuratulain, Dr. Rima Aslam, Dr. Shehnaz Bakhtiar, Dr. Umar Khalid Chima, Dr. Zamina Malik, Dr. Farah, Ms. Farah Adiba, Mr. Farhan Akhtar, Mr. Farhan Ali, Mr. Farzana Shabir, Ms. Farzana Shabir, Ms. Fawzia Bibi, Mr. Kohar Ali, Mr. Gul Munir, Mr. Habibullah, Mr. Hafizur Rahman, Mr. Hazrat Bilal, Ms. Ikra Shafiq, Ms. Ihram Amjad, Mr. Irfanullah, Mr. Irshad Ahmad, Mr. Izaz Ahmad, Ms. Khatija Zaria, Ms. Komal, Mr. Lalji, Ms. Madiha Gulfam, Ms. Mehwish Rauf Sheikh, Mr. Mehtab Ali, Ms. Mehwish Javed, Ms. Mehwish, Ms. Mishal Nadir Naseem, Mr. Muhammad Arsalan, Mr. Muhammad Atiq, Mr. Muhammad Awais Khan, Mr. Muhammad Junaid Khan, Mr. Muhammad Pervez, Mr. Muhammad Ramiz, Mr. Muhammad Shiraz Khan, Mr. Muhammad Wahid, Mr. Muhammad Yasir Majid, Mr. Muhammad Zahid, Mr. Muhammad Zishan, Mr. Muhammad Zubair, Mr. Mushtaq Ahmad, Ms. Nabila Arif, Ms. Nagina Shehzad, Ms. Nahid Khurshid, Ms. Naila Gul, Mr. Nasibullah, Ms. Naseem, Mr. Nasir Hayat, Ms. Neelam Shehzadi, Mr. Nurul Hadi, Ms. Noreen Bibi, Mr. Noman Ali, Ms. Kestra, Ms. Kuratulan Urusa, Ms. Rail Muhammad Danish, Mr. Raja Prem Kumar, Ms. Rehana, Ms. Rima Khan, Ms. Ruqayya, Mr. Saad Mia, Ms. Sabah Aslam, Ms. Sabiha Nas, Ms. Sabina Shiraz Ali, Mr. Saidullah, Ms. Safina William, Ms. Safia Bibi, Mr. Saghir Ahmad, Ms. Sahar Parvez, Mr. Saif Ahmad, Ms. Saira Ashraf, Ms. Saira Bibi, Ms. Saira Parvez, Mr. Sajid Ali, Ms. Samina Kausar Amin, Mr. Sanaullah, Mr. Sanam Shehzad, Mr. Saeed Amjad Ali, Mr. Shah Khalid, Mr. Shahid Hussain, Mr. Sahibullah, Ms. Shaista, Ms. Shaista Riaz, Ms. Shama Izhar, Ms. Samreza Zulfikar, Mr. Shay Muhammad, Ms. Shumaila, Ms. Sidratul Muntaha, and Ms. Sobia Khalil, Ms. Sumaira Shabir, Ms. Sumaira Samreen Akhtar, Ms. Sunira, Mr. Sabil Gil, Ms. Saida Anila Batul, Mr. Sylvester, Ms. Tabinda Aftab, Ms. Tanzila Tibibi, and Ms. Tahmina Nazneen, Ms. Uru Sultan Niazi, Mr. Wasimullah, Mr. Yusuf Ali, Mr. Zahid Imanullah, and Mr. Zahidullah. And thank you so much. These are our participants who graduated this year, and I heartily congratulate you all. So I can stop sharing this. All right, so it's time to recognize our participation's hard work. And now we are moving towards the closing ceremony and the closing remarks. Unfortunately, Dr. Samreen Sarfraz, our IC chair, is unable to join with us today. However, on behalf of Dr. Samreen Sarfraz, I would like to invite Ms. Shabnam Bilal, our IC manager, will provide the closing remarks. So Ms. Shabnam Bilal, please, now it's over to you.
Thank you, Dr. Nima. Assalamu alaikum, everyone, and congratulations, all of you. First and foremost, I would like to thank all the wonderful people, all the speakers, faculty members, and students. All of you taking time out of your busy schedule. My deepest gratitude goes to Infection Control Training Center, Indus Hospital, especially Mr. Farhan Zafar, Madam Arfa Khatun, and whole IC team. They did dedicated work, hardworking, and with enthusiasm. And congratulations for all the students who passing out this year and achieving the diploma. Now we hope that you will implement these IC practices in your healthcare setting. As Dr. Shahin Mehtar and Dr. Altaf Ahmad share with us, infection control is a paramount. It protects both healthcare workers and patients and prevents and provides safe environment for everyone. So now wish you all of you and very good day, and thank you all of you, and keep continue these practices, and thank you very much.
All right, so congratulations to the diploma graduates. Your hard work, dedication, and perseverance have paid off. And we wish you to continue success in your future endeavors. But before we signing out, I just want to request you all to open up your camera so we can take a screenshot or a picture for this graduation ceremony. Can you please, everyone, open up your cameras? So I have seen some faces right now, but there are still some people who didn't open their camera.